Hi, welcome to House Healthcare. It's Friday, February 2nd, and we have Department of Mental Health with us today to talk about their budget. I also want to say that Representative Tiff Bloomley from Appropriations is here. So please reach out if you have questions. I'm happy to include you in the conversation. I'm going to turn it over to you, Emily.
Good morning. For the record, Emily Hawes, Commissioner for the Department of Mental Health.
Allison Crump, Deputy Commissioner, Department of Mental Health.
And I'm Shannon Thompson, the Financial Director for the Department of Health.
Thanks for having us here this morning to talk about our FY25 budget. I'll do a quick re-level setting just to make sure that we're reacclimated to our system. But I think we've been here one or two times this session, so but happy to answer any questions if something comes up. So as a recap, back in 2020 and 2019, the Department of Mental Health engaged in an extensive stakeholder engagement to help define where we are headed with a 10-year vision, and that's referred to as Vision 2030. So hopefully some of this is familiar with policy asks that we've had over the past couple of sessions as we move towards improving the client experience, improving the health of our population, reducing costs of care, and improving the healthcare provider experience. The Department of Mental Health oversees and designates 10 designated agencies, 2 specialized service agencies, and 7 designated hospitals. We operate the Vermont Psychiatric Care Hospital, which is a 25-bed facility here in Berlin, serving adults who are under the care and custody of the commissioner. And then we also have River Valley Therapeutic Community Residence, which is located in Essex, and that's a 16-bed community facility. As a department, we have 308 positions. 235 are split between BPCH and River Valley, and then we have 73 central office positions. Collaborate across our system with hospitals, forensic psychiatrists, law enforcement, University of Vermont, other state agencies and departments, and then we also collaborate with our Vermont Care Partners, the Vermont Federation of Families for Children's Mental Health, Centers for Health and Learning, NAMI, the National Alliance on Mental Illness, Pathways, and many more. Just a quick snapshot of our mental health residential and crisis capacity. From the designated agencies, we have 38 adult crisis beds, 18 youth crisis beds, and then 42 beds for adults who need intensive residential. Our designated hospitals with level 1 involuntary, we have 59 of those beds, 25 at Vermont Psychiatric Care Hospital, 26 at the Brattleboro Retreat, and 6 at Rutland Regional Medical Center.
Go ahead, Art.
How many of these beds are staffed? Are they all staffed, Emily? Is that what just these are the numbers that's staffed, or is these the total beds?
Those are the total beds that we have in the system. This is not broken out by what's staffed and what's not staffed.
It is not. Okay. Just or occupied.
Or occupied. I do have those notes in one of the slides, but I can't see the note slide.
All right. No, that's fine. I just thought of that.
We have seen, in general, there are crisis beds open. There are not necessarily a lot of crisis beds closed. I think maybe 6 adult crisis beds and 3 to 5 youth crisis beds.
That are open.
That are closed.
That are closed. Gotcha.
Brian? Sorry, Brian, you had a question?
Yeah, I looked ahead to see if it's coming, and I didn't go too far, so I don't know if it is. But although I work in the system of care, I couldn't tell you where all the adult intensive residential beds are, like in terms of how they're distributed. So I'm curious if you might be able to say, you don't have to explain it all, but maybe just give a few like a few
We have a
examples.
slide for you.
Okay, and then,
Talk about that.
and then the other thing is, where this is leading though, is like, do we have a sense of what the unmet need is?
Yes and no. I mean, I think there's some needs that we might not necessarily be aware of yet. But we do have a good idea of where some gaps in the system are, and that's why you've seen some of our policies target that with like mobile crisis response and urgent cares. We'll talk a little bit today about psychiatric rehabilitation treatment facilities, or PRTF, which is a known gap in the Vermont system. So we'll talk a little bit about that, but here is the slide that it's not that big, so you'll have to expand it.
Yeah.
That really focuses and lists out where those resources are in the state.
This is great.
And I believe this was a recommendation out of this committee during one of our recent testimonies.
Yeah, thank you very much. It's very helpful.
There was one other question, and if you don't have the answer, it's okay, but do we know how many people might be incarcerated who actually need these kinds of residential placements?
Oh, I don't know.
Okay, I don't know if we know. Okay, thank you.
Thank you. This is really good. I'm looking at Wyndham County because that's my county and that's what I know. And I just want to understand what other means.
Oh, sure. So other are facilities or programs that are run by agencies that are not the designated agency. So above that line, you have ACRS, Meadowview, and Hilltop. But then there are other businesses and programs who are run outside of HCRS.
So that's where the Brattleboro retreat would be in the adult psych hospital. That's,
Yeah.
okay. So those beds, the 58, 20, and then 30 are all retreat beds.
Yes. Yep.
And then the others are, I'm not sure I know, the acronyms are on the side.
Yeah.
Okay, I can find them. That's
Youth
good.
HDP is Youth Hospital Diversion Program.
Mhm.
Youth PNMI is a program that's funded under the PNMI rate, which we will talk about later in our presentation, and then youth micro residentials.
Thank you. What does micro mean?
Small.
I know it means.
Yay! I'm so sorry. That sounded sarcastic. It is a small program geared towards specific youth intensive needs.
Okay.
I was looking at the PS services.
So we're back to the slide where we got derailed.
Okay.
That, at least in my mind,
Mhm.
it appears to be a small segment. Is there a reason why PS services, there's 7 beds? As it down
Oh,
20
the
stuff?
adult crisis beds and the adult intensive residential. The 5 residential yeah. So, yes. That links directly to some of our work with the peer credentialing, and a path towards billing Medicaid, for some of those services. I think historically there has been challenge of funding because typically I believe they're under general fund for our peer services, but I'll ask Shannon to confirm that.
I was just wondering whether or not it had anything to do with, it might be more difficult for a peer that's been through some crises, talk to somebody else because of a trigger, what's going on with them. And I just give you an example.
Sure.
There was a time in my life when I was involved in that. And it was one-on-one with the psychiatrist. And then I went to a group setting. And in the group setting, the first couple of times I was there, it riled me up.
Yeah.
And that's what I was wondering, is it hard to get peers to work in this area?
That's a really good question, and I appreciate your disclosure of your own experience with that. I have not found that we have challenges finding folks who want to support other folks with similar lived experience. I think with adequate training and support through supervision, folks who may have that initial response or may not be quite ready to support someone with lived experience, that can be really beneficial. And I think you see this a little bit in the substance use world as well with their peer recovery coaches. There's a training program that goes into that certification that really talks about how do you navigate hearing really intense stuff and being able to support them and not making it about you, being able to connect with somebody with similar lived experiences. I know you folks have taken some testimony around the peer certification bill. And so from a mental health perspective and moving towards peer certification for there, it's a similar but separate. I think the end goals can be different depending on what you're working with somebody on. But from my experience, I've seen those programs be quite successful. We have Alyssum over in the Rochester area. And that program has done exceptionally well in supporting folks as step down from hospital setting, community referrals, and or from the emergency department.
Well, the interesting thing about that is after I was involved in that group setting for a while, we turned around and then we helped other people.
Yeah.
I
Yeah.
mean, I could actually do it
Yeah.
without getting all
Yeah.
bent out of shape about something I shouldn't have been bent out of shape for.
Well, I think what you're describing is just that evolution of somebody being able to be supportive of someone with
Oh, yeah.
similar experiences. There is a training piece to that, just an internal understanding of how, your interaction with the world can be similar, but isn't the same interaction as others, but you can connect on, how to be living in the way that somebody wants to live, and you can support them with that.
Okay, so it's-
Anything you want to add to that? No? Okay. Oh, let's see. I think I had just started off around our designated hospitals, but folks know where those are. Those are your UVMMC. There's general beds at Brattleboro Retreat, Wyndham Center. And then we also have the River Valley Therapeutic Residence, which is 16 beds. And here we will display our familiar pyramid. We've also talked about inverting it to a funnel because we want folks to really understand that the foundation of our system is our community mental health programs. And those are the bottom, first, and second layer to this.
Thank you for adding the beds to this as well. Go ahead, Art.
Yeah, a question on the EDs and the beds.
Sure.
So we, I think, still have a waiting list of folks with mental illness situations and EDs. If the bed's available, why is the number 0 in our waiting list?
Yeah, that's a good question. We used to frame it as an open bed isn't necessarily an open bed. There's a lot of complexities that can go into that. I will say that there are beds across our system today. There's multiple beds available at Vermont Psychiatric Care Hospital. Things that can delay somebody's referral is just the emergency department, just getting the referral information to the accepting hospital. And I would say that's the same for people who are needing higher level for inpatient psychiatric care, but also med-surg, just getting the information to the right folks to review it, to make sure that they have all the things in place. Transportation can impact somebody's stay. The unit where they're going can impact somebody's length of time. But I think the most recent report that I have is folks are getting placed much quicker than they were a year ago. And typically, less, if they need hospital level care, less than 24 hours, I believe,
Okay.
on average.
So we have the spectrum of care that we can send people. Okay,
That's correct.
good to know.
On those wait times, is that involuntary and voluntary? Do you see the difference in between the two?
Yeah, we typically voluntary folks, and we don't see all voluntary folks. We see voluntary Medicaid. So there's a host of folks who are accessing, who have private insurance. So I can't speak fully to what their rates are, but I know the VOZ report, I think, does capture that. And so typically somebody who's on an involuntary hold does take a little bit longer. But those weights have really come in line with our voluntary, for the most part. We're not seeing wide swings in voluntary versus voluntary today.
Great, great, thank you.
Okay, so this was a follow-up from this committee, and so I'll pause here for a minute to see if there's any more questions related to the map and where services are.
Very helpful. Thank you.
Okay.
I was gonna.
Okay, sure.
I just can't help but notice the Northeast Kingdom is woefully short.
Yeah.
Yeah,
And where are those two adult crisis beds?
sure. Do you want to talk about Northeast Kingdoms?
The good news is the Northeast Kingdom is this close to having their front porch program done, which is going to be 6 crisis beds and an urgent care front space by peers. And so that's about, they're purchasing the building right now. And so, but they have had issues with trying to figure out where to place things because they need to be able to staff them. And they need to have it be in a place that's relatively easy for folks to get to. So that hasn't always equaled to finding a place on the map that's empty and placing something there. And so right now, they're limited to St. Johnsbury. That's the latest on where this is going to be placed.
Okay, so that's gonna add 6 more to that, but where are the 2 existing now?
The 2 existing right now, they have in, I can't tell you exactly what town it's in Northeast Kingdom, but they have a crisis bed and a PIP bed. They're together. PIP is the public immediate bed program. I can't remember which town it is.
Lindenville? I think it's Lindenville.
Okay.
I just remember the dirt road and I was like, where were we? I think it was Lindenville.
Okay.
Yeah.
Thanks.
Okay, great. So I'll move us into our summary of proposed expenses and budget requests for FY 25. So I will turn it over to Shannon Thompson, our finance director.
Thank you.
I'll move this closer for you.
That would be awesome. Thanks. I will try not to dump it on the floor. Oh, thank you. So this first slide here is the summary of our whole budget. We are requesting a total budget of $321,419,599. The total ups, the gross ups are $3,890,901 with a general fund equivalent of $1,582,080. What we have for requests this year are primarily around salary and fringe, the benefit rate changes, internal service funds. We do have psychiatric contract increase for the Vermont Psychiatric Care Hospital, increases to 988 activities, private non-medical institutions rate adjustments, mobile crisis fund conversion from from general fund to global commitment. And then Vermont legal aid, additional legal staff and conflict counsel. So we have what makes up that $321 million is $25,507,000 of general fund, $1,718,092 of special funds, which is our Medicare billings at the hospital and other per diem billings from clients at the residential and from folks at the hospital. We have small amount of interdepartmental transfers. Federal funds, we have $11,436,913. And then our Medicaid Global Commitment program funds of 232,152,581. And then we have Global Commitment Investment Funds of 50,590,745.
Can you explain the difference between federal funds, Medicaid, global commitment funds?
Yes. So federal funds are federal grants, primarily federal grants that we have, and it's some of the administrative salary and fringe that are associated with those federal grants. So that's primarily what that is. And the global commitment is all Medicaid. So we have two different Medicaid buckets of money. We have the investments, and then we have the programs. The investments tend to be like we do support our peer services with investments. We have investments to take care of the uninsured or to help cover for uninsured and underinsured and those Medicaid services that might not be Medicaid eligible with a service level utilization. Also, it supports our Vermont Psychiatric Hospital.
So we had Diva in here this week and we talked a lot about investments. There's 83 of them. Is that the same? Is that the group you're talking about?
I'm not sure what investments that Diva was speaking about.
So it's basically the money that comes in from the federal government through Medicaid for things to fund and match that's not included in the global commitment. There's like a list of 83 and they span across all the agencies. That's the same category that you're talking
That
about.
was probably the same.
Okay, great.
I would have to, yeah, I'd have to.
Yes, okay, thanks, Nolan. And then is this 232 million all federal? Is this, or does this include the general fund match?
Yes, good, great question. It does. It includes, so global commitment, Medicaid is made up of federal funds and general funds. It's about, I think it's 42.17% is general fund and then the remaining is federal.
Okay, great. And then the general fund, like, give us an idea of what that covers. Stuff that doesn't have a Medicaid match.
That's correct. It does not have a Medicaid match. So a lot of our funding for the Vermont Psychiatric Care Hospital is general fund because it's an institute for mental disease. So we're phasing out the use of Medicaid for that. That's a lot of what that is.
Mike, she just answered my question. Thank you.
Art?
Oh, I just verified, this book doesn't contain
No,
any of
that's
that.
just Diva.
It's just Diva. Do you have any spreadsheet type stuff for DMH?
So they would have the ups and downs document, just like all the other agencies do.
Yeah,
And we can show everyone later where to find that.
all right.
If it's not in here.
Yeah. Thank you.
Yeah, you'll see in the presentation, we have narrative rather than the actual spreadsheet.
Yeah,
But we can get to the
we
spreadsheet.
can figure it out,
Yeah.
yeah, all right.
Okay.
Yeah.
Oh, sorry, go ahead, Topper.
For years in this building, we've been trying to put physical and mental health together. And I'm wondering if, I don't see how the budget reflects that yet. Is there movement at all amongst the Department of Health, of the mental health?
You want to speak to that?
Yes, we were legislated to convene on that very issue for the Mental Health Integration Council. And so Dr. Levine and I did send in a report at the beginning of January, it would come. And that was 2 years spent with healthcare and mental health, as well as Dale and many others. So we had private insurers there, we had UVM Health Network, we had a host of individuals coming together to say, how are we integrating mental health into healthcare? I would say where the two areas where there's been a lot of movement, and you'll hear about it with the blueprint for health and some expansion of the hub and spokes to have more mental health services. So taking some spaces where people go for their healthcare and making sure they can get mental health care there. The other is this work towards CCBHCs. And so that's the certified community behavioral health clinics, which we are working on changing that name.
The acronym.
But that is a space too, where somebody who goes into that space for their mental health can also get some healthcare, primary healthcare screenings. So those are two big areas that I would say have really had a lot of movement in the past year or two.
I don't think another one would be the primary care area.
In mental health,
Yeah,
yeah.
Yeah, yes, absolutely. I think that's part of what the blueprint's been working on, is getting more clinicians embedded in primary care.
so I guess the answer to my question is something's happening. And maybe, before I leave this building. maybe it-
I can tell
You guys will be sticking around for a couple more years. Just kidding.
If you think of it as a trajectory of like your career, in the past 3 years, we are meeting with the other departments on these issues. I would say 100% more
Yeah.
than it was 5 years ago. It is a constant, and credit to AHS that is a vision of theirs. So we're meeting with substance use, we're meeting with VDH, you know, and Dr. Levine and I spent 2 years together
You know,
convening this group. So it's definitely, they're pushing it from the top.
it'd be nice seeing it on the ground,
Yeah,
Agreed.
you know.
great. Thank you for that work. Okay, keep going.
Right, I'm sorry, go ahead. Waiting for I'm just wondering in this summary, what's missing? What did you wish you could have that you didn't?
Can we hold that to the end so we can get through what we did and then we'll come back to that question? That would be great.
Okay, so this slide is just kind of, it's breaking out some of the programs for you and the related costs associated with these individual programs. So I'll start over here with the adult services. That includes our CRT, adult outpatient, peers, emergency services for adults. And that's about $106 million there. Then we have inpatient, which is Rutland level 1 beds mostly. We have suicide prevention. I believe that's 1.8 million. The screen is over it for me. And then we have Vermont Psychiatric Care Hospital, that is a $32.9 million expense. River Valley is just over $9 million. Children's Community Services, that's the mental health case rate for children, peers, and other federal grants for $61,645,000. We have Success Beyond 6. We have a budget of $72,250,289. Then we have the Children's Residential PNMI, which is private non-medical institutions for children. That's just over $9 million. Mobile Crisis Response, $9.3 million. And then DMH administration and other contracts, just over 13.2.
Leslie?
I'm not sure if this is further in your presentation. In the Success Beyond 6, I know that's the mental health program for schools. And I've been hearing from my superintendent some frustration with that program and that they've had to kind of go outside of it to get mental health support for their schools. And I'm just wondering if you guys are thinking about that and if you're working with AOE and how that looks.
Yes, we are thinking about that, and working closely with AOE. We know that there are staff vacancies, that may be impacting, access to, support youth in schools, who are who have Medicaid under Success Beyond 6. We also, know that there may be some other complexities that are directly impacting folks getting services in schools under Success Beyond 6. So yes, we are in close conversations with AOE around how can we figure out how to support youth in schools better or differently, both from DMH Medicaid, which is the Success Beyond 6, and then also Agency of Education in schools. There are other Medicaid buckets that they have access to.
Can you imagine a timeline of intervention, or is this sort of open-ended for the moment?
Timelines are hard. I think that there are some opportunities federally that are coming out around supporting youth in school, and you see me conflicted. I like for programs to have a chance to work they oftentimes don't work as fast as we would like for them to work. And so I would hope that some of the conversations that we're having with AOE are move the needle just a little bit, even in the next year. And so we do have some hope with that.
Thank you.
Anything to add from your lens? Sorry.
No, you're fine.
I would just add from where we said at DMH, we would see a bigger picture on how much more you can leverage by using Success Beyond Six and partnering with a designated agency, because they have access to strong clinical supervision as well as other services for that youth. And so we really are trying to make sure that we're promoting that, make sure people see that full picture versus trying to go it alone, which is costly, and you end up standing up a siloed clinical service in school.
How worrisome, yeah.
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 If we budgeted more state dollars to the DAs, would that allow them to hire the things they need to draw down the federal funds to make sure we're reaching our maximum capacity?
I think we'd have to take a look at the full picture of what leads to those staff vacancies. And also those, each supervisory union operates as their own, approach to serving their communities. And so I think it would be helpful to really understand, is it, what prevents folks from accessing those Success Beyond? Is it a rate issue? Is it solely just a body issue? I know that there's a heavy administrative burden that we've been working to decrease. So I don't know if it's all money, but it's certainly worth taking a look at targeting that specific, population to get folks engaged.
Thanks, Tip.
Yeah, I just wanted to ask what the impact on general fund draw would be if we were to be able to access this federal funding. Or would you use the federal funding simply? I mean, is there such a need that you would need the same general fund appropriation plus?
What are you referring to, the federal funding that I mentioned? Yeah. So that is not for services specifically. It's a NOFO for technical support and policy development. So it's not a delivery model, but it's how can you streamline your current models to deliver more effective and efficient services. So I'm not aware of a general fund requirement of that.
Okay, thanks.
And I'm assuming you're well aware of the conversations happening in education, and we'll be joining them next week for another joint committee. So this is obviously a great concern to us. Yes. Okay, thanks.
Okay, so this will be the first set of line items on your ups and downs that you may have. I see there are some here. The ups and downs, the first item is going to be around salary and fringe increases. And across all of these categories, the salary and fringe, the salaries, the healthcare, retirement, and other payroll benefits, it's a gross need of $2,829,864 for a general fund equivalent of $1,818,874. And then we have internal service fund for workers' compensation that actually has been reduced this year by $62,468.
So one, maybe go back a second, Art. Is it?
Yeah, on those figures, is there a way you could add percentages up from fiscal year 24?
Oh, from the
Can we
previous.
put percentages in there so we get a sense of what these numbers mean?
Are the percentages on the ups and downs spreadsheet? No.
Just numbers.
Okay.
I was asking maybe if the percentages were on the ups and downs spreadsheet, but they're not.
But
Oh, I mean, you can get a sense of it from
Yeah.
the spreadsheet.
Yeah.
Yeah, you can figure it out. Just here, you can't quite figure it out. That's all.
Yeah.
Yeah.
So Nolan did send the spreadsheet, the link to the ups and downs spreadsheet out to everyone.
Yeah, right. I've got it. I just saw if it was here. it'd be
Yeah.
easy. That's all.
and
I think there is sorry, Nolan. I think that there is, in the Vantage system, I think there is one of the reports gives percent
But we don't get Vantage, they don't know what Vantage is.
Sorry.
I'll figure it out.
But for the record, no line, yeah, for the joint fiscal office, on the ups and downs, which DMH is on page 14, the bottom of that, there is a line under the blue that has total increase, decrease by line, by fund, so you could get a sense of that, and I showed it to representation yesterday.
No, I'll figure it out. I just thought
Yeah.
it'd be easy here.
So I do want to point out though that for salary and fringe increases, to look at the total gross and get a percent does not necessarily equate to like salary increases. Sometimes there's additional positions in there that we were able to get in the last session. So I believe them, you'll see that the mobile crisis positions are in there. There were some classification increases due to our request for reclassifications. Things like that are in there, but there are also some extra positions that we got in last session. So other personal services, as I was just mentioning, we had in 24, the request, we requested $945,000 for RFR and class action reclassification changes for our care managers, social workers, mental health specialists, and we also had 4 mobile crisis positions. All that money was put under other personal services at that time. Now it's part of the salary and fringe. So those are the things that I was just talking about. Those positions are actually in a
Sit in salary and fringe now.
with the exception of 2, there are still 2 positions that are not, we do not have position numbers for, so that's still in there.
Melanie? But they're still held and are they vacant or are they still held and they're not being reduced? They're just being held in a different way.
That's good. It's just the funding for them is being held in the other personal services because we don't have a position to put into the salary.
But we're maintaining it so that.
Yes, absolutely. Yes, we are actively trying to fill those positions. Recruit permanent.
The other request for review or RFR process is part of retention and recruitment, making sure that our social work positions are in line with similar hospitals. And we also had our mental health specialists re-looked at through the Willis system through classification to see if those changed, and those help us hire new staff in, but also keep the staff that we currently have. So we did that for the facility. We've done that for central office care managers who help to manage the whole system in and out. And then we're considering looking at doing that for some of our cook positions, which are very low. You know, when you look at neighboring facilities that have similar positions. So we haven't gotten to that point yet, but those are some of the tools that we have within the collective bargaining agreement that allows us to have some flexibility with retention and recruitment.
And when you say facilities, River Valley.
Yep, River Valley, VPCH. So for example, Vermont Psychiatric Care Hospital has a kitchen and kitchen staff. And there was a recent development at the Berlin Mall space that is an assisted living who also has a kitchen. And so it's similar type of work. Also next door at CVMC has a hospital kitchen. And so wanting to make sure that we're consistent in how we pay for those similar positions.
So if someone's position is determined to be of a lower classification, is their salary then changed to be a lower salary, or how does that happen?
I've never seen it go down. They've been rated with a current job spec. And so I haven't seen it be rated low and go down. And I don't think the Willis system allows for that. So what typically happens is you submit a new RFR that's detailing out the work that position is doing. And more often or not, they say it's classified appropriately, or it should be, let's say it's a 23, maybe it should be a 24 pay grade based on the Willis system. And if there are other departments or agencies that have the similar position, it raises everybody in that position.
How are there savings on this line item then?
So what it is the funding for all of this was in the FY '24 budget. So we're taking it out of this particular line item and it's now up into the personal service line item. So those salaries have been increased now. And so now those positions are at those higher
Levels,
rates.
okay.
So that's where the money is. We're just moving this money out of here because it's no longer under that line item. It's up in the actual salaries.
And in the contracts that staff have with the state, is that allowable? That through the RFR process, they could be reclassified to a lower status?
Rated. I'm not sure. I'd have to find out.
I'd like to know that.
Sure.
Yeah, I think, I don't know if it's possible or not. I've actually never had that happen. But if it were to happen, there are rules around if you go one pay grade below, one or two pay grades below, you maintain your salary. You don't get a
lower
decrease for that.
salary.
I think if it goes a certain number below, that might make some changes, but I've again not experienced it like Chris.
Yes, BSEA, not a question for you. I'll follow up with them.
Yeah, BSCA or our HR partners.
I'll ask them.
Okay. So the next item is our contract with Columbus for the Vermont Psychiatric Care Hospital. That is a gross need of $862,000. And because it's supporting the hospital, it's all general fund. Any increases for the hospital, we have to put in its general fund. So we learned in FY '24 that UVM MC, the University of Vermont Medical Center, will no longer contract with the state of Vermont for the psychiatric services. So we sent that out to bid using the RFP process, and Columbus was awarded the bid.
Hold on there. Sorry.
So the 862,000 is the increase since you had to get new contracts. And you may not, did UVMMC give you any indication as to why? Was it related to shortage of psychiatrists?
Yeah, I think, and they of course could speak to this themselves. I think it's a mixture of, there is a shortage of psychiatry in the state. They were using locums at the time on their own unit, which is also very expensive. And so I think as a business decision, it made sense to bring psychiatrists who are delivering care at other facilities to the home base, so to speak.
Yes, thank you.
Yes, I wondered how many contractors you sent contracts to, how many bidders did you identify and send out?
I don't believe we identified, I believe we just sent it out as a.
It was a broad-based
open for
RFP.
anybody. who
Yeah,
wanted it.
anybody could have applied for it who met the eligibility. Are you asking how many folks responded to it?
Well, I wondered how many bids you sent out.
We don't send out the bids, we receive them.
So they send out a request for proposal that says,
Who?
they have a process that they use, so it goes out broadly. You can find it on the website. And so the process that the government uses, state agency uses, and then they receive the bids back.
How many bids did you receive that? You know,
I can't remember off the top of my
I don't
head.
remember how many bids.
do you typically pick the lowest bidder or how do you determine it? I'm just curious.
Yeah, so we go through a rating process. Cost is a part of that rating process. But also the experience with the population, how fast they are able to recruit and deliver the service. So there's quite a few different factors that we look at when we're rating and
So Columbus is based here somewhere or?
Columbus is not based here. They are a national company that staffs and provides services to state hospitals private entities, corrections, they have numerous.
Yeah.
But one thing that was, we appreciated about them is that they have, the physicians are placed for quite some time. I think their average was like 10 or 12 years at one facility. And so that was really valuable to us. And so during that transition time, there was a decrease in how many individuals VDCH could serve. As we transitioned from the UVMMC contract to the Columbus contract. So all of those psychiatry positions have now been hired. And I think the last individual starts, I think in April. And so that's great. Some were from Vermont, and some had just, and I think the last one is just recently finishing up his residency.
Great, thank you. Melanie?
With this change to the Columbus program, do you see any new advantages or services they provide with this additional cost, or is it just comparable to the UVM?
And some of the doctors were UVMMC physicians that the Columbus folks contracted with. And so there's some continuity of care there. What I think is also beneficial is the amount of resources they have should we experience a doctor shortage at the facility. And so the Columbus contract provides all of the psychiatry services, but also all the medical services for VPCH. So I think from my perspective, just that ability to help support if there's some sort of tragic, unexpected leave of absence.
All right, thank you.
And just to expound on that, so these folks that work at Psychiatric Care Hospital work for Columbus, not us.
That's correct.
Okay. All
Well,
of
the
them?
physicians do.
Okay.
Nurses, mental health specialists, social workers, kitchen, custodial maintenance are all state of Vermont
Okay,
employees.
so there's an interface there between the two.
The contract, yep,
Yeah, okay. All right,
that's correct.
thank you.
Thank you.
So this next item here is $25,000, and it's a mandate, legislative mandate that was funded with one-time funds during FY 22. We've kind of just cobbled it together for the years after that. Act 57 is where that funding came from. So this is a budget request to take care of the conflict council portion of that.
What Conflict Council does is provide the Department of Mental Health access to outside representation outside of the Attorney General's office, if and when we need that.
Good.
I hate that, but I have to ask,
Yeah, okay, go for it.
ARPA funds or other one time?
It was, I think it was general fund.
General fund
One-time fund, but I wonder if that might have been just an oversight at the time when that legislation passed, because there were
Okay.
unfunded mandates as a part of that, but
I
it was before I got here.
Yeah, we're trying not to continue to fund ARPA.
Understood.
things. All right,
Yep.
yeah.
Okay. So then the next set of items here is all of the internal service funds. The total amount is $245,760, or the general fund equivalent of $192,308. So that's just your fee for space, insurance, general liability, vision, which is the accounting system, ADS charges, and human resources.
We saw that in Diva too, so, yeah. Okay.
This one here is funding to maintain the 988 suicide prevention line. It's a gross of $451,254. General fund equivalent of $190,294. I don't know if you want to talk a little bit about that.
Yeah, if you want to show the next slide.
Can we just stay on the money for 1 second?
Oh, sure.
Melanie, I think you have a question.
Yeah, I was just curious because we heard some wonderful presentations earlier this week about the efficacy and the success of this program. And one of the goals was to be at 90% live in Vermont answering, which is a really great goal. And I'm curious if this 190,000 is enough funding to meet those needs, because they were speaking about changes to the system that might need to be done in order to meet the goal, which is a really great goal. So just curious, speak to that.
Sure, that is the goal, and that is the calculation that we ask the centers to look at for how much staff do you need to get to that goal. So yes, it's definitely the target we're aiming for. The national group gives us a calculator for staffing. Doesn't really apply well in Vermont. I think our numbers are just so different than other states. So I think we've had to have more staffing than people might think to cover it 24/7. And so we're looking at those numbers. They've come real close to that 90. I think we'll get there. And we have some data on what it's looked like over time.
So wait, go back, sorry, not done yet. Sorry. So, the SAMHSA grant is running out, right, on July 1st, so
Yes.
this would start on July 1st. So what is so this is 451,000 is really all we need in our base budget to fund this, or is there already money in the base budget and we're adding this to it?
There's already money in the base budget, and we are adding this to the base budget because those grant activities that are to fund the base grants to these two agencies, plus we also have Headrest, which provides backup. That funding is running out with the SAMHSA grant. So as of July 1, we'll need to be fully funded for that. We do have another grant that funds activities in addition to this that we'll be talking about a little bit later.
Yeah, so what is the total amount that is needed to run 988?
So currently in the base, there's 715,200.
Okay.
We're asking for 451 change.
Okay,
That is still, so what that's for, kind of the core set of answer the phone, chat, and text.
okay,
This other grant is to a little bit about your point about, are we going to have the ability to do everything we want to do with 988? There's a second grant that's offering that's funding some service coordination. It's looking at coordinating with mobile crisis from 988. So those pieces are now funded by a federal grant to get us to see what that can do, and then get us to there.
The next
to
point.
likely see another.
okay. And so when does that grant start and end, and how much is it?
That grant, that grant has started.
Okay.
It's $955,000 for the first year. But we have, like, I just submitted last night, our continuation for the second year. And then we have the opportunity to ask for a third year. The second and third years are at 900,000.
Okay,
So the first year is a little bit more.
okay,
And the
great.
chunk of that is for an IT solution, just to be clear, so that's likely not something that may carry forward.
Right, okay. Topper, and then Art.
Is any of this money going to, there was a place in Lebanon, I think? And then
Headrest.
the national group. Is any of this money going there?
Go ahead.
Yes, we do have a contract with Head Start. Headrest. Very close. Headrest. And we have a spreadsheet that details what goes to Headrest, what goes to NCSS, and what goes to NKHS. I don't have it in front of you, but I could share that.
Send it to us, that'd be great.
Thank you.
Art?
And maybe Lori or maybe even Nolan can answer this. How many different places is 988 in the budget? It seems like is it only here?
Yeah, and they can answer that question.
Okay. Is it, so the funding for it's here. What did we have the other day about it? Who presented?
Oh, they were just presenting because they're the ones that manage the call centers. So it was the two designated agencies that actually do the work.
All right.
So that was why they came in,
Okay.
but all of the funding is in DMH, yes.
That's all I need, yeah.
Thank you. We love this. This is very important. So we went, and we knew it was funded by a grant. So this is helpful. Sorry, so you can go to the data, which we also love to see.
And so what you're looking at here in the aqua blue, those are the numbers for monthly call volume. And so the aqua blue is when the phone started ringing. And back then it was the 1-800 number. It wasn't 988. And what you'll see is a tick up around here and then moves to 988 as the 3-digit call line. And so if you follow that blue line, as you see, since it's become 988, the volume has increased significantly. And then we started this chat and text. Chats are in the yellow, texts are in the darker blue. The difference between a chat and text is if you go, say you Google 988 or Google I need help, feeling suicidal. When you go to the 988 website, a little thing will pop up and say, would you like to chat? So that's what that is versus just somebody picking up their phone and texting the numbers 988. That's what a text is. So we've seen that start to tick up. And we are learning a lot. I'm sure you probably heard this from the agencies, what it takes to answer volumes for chat and texts. And that right now we don't have set at a 90% target. We'll be looking at how we can build up that capacity.
Okay, any questions on this? Amazing.
Can you just remind me what the 90% target is, sorry?
So 90% target is of the people who call 988 for Vermonters, we want 90% of their calls to be answered in Vermont. So that means that there was somebody available within our own system. Doesn't mean the phone doesn't get answered. So if someone's on the phone at NCSS and they're the only staff, the call's going to kick to actually headrest. That's our backup because we want to try to keep it as good as possible.
So does this, so you were talking about this budget not supporting getting to the 90%. Did I get that right?
But the budget is designed to staff enough to get 90%
Okay.
of state call.
Great, thank you.
Doesn't mean.
That's enough to aim for the goal. Yeah.
I may have missed it when you were giving numbers of grants and all. What is like the total dollar amount that goes to 988 between all sources? We're funding this year.
With this 500, well, so we have a spreadsheet that will lay that out. So we have the base funding that we're asking for that's about between 1.2 and 1.3 million. So it's the 715 plus this 541. But then we do have these other federal grants, or this other federal grant we call cohort 2. That's the 955,000 for 1 year, and that goes through September of this year. And then we've re-upped that for the next year to get us through September of 25. So I do have a spreadsheet that outlines all of the funding for 988.
Do you know what the total we spent last year was?
I could get that to you.
Okay.
Daisy?
Are any of your CCBHC planning grant awardees using that money to maintain the 988 work that they're doing as part of the crisis response requirement?
So, of the agencies that have the current planning grant or the two that we've chosen to do the application?
Any of them, or you as the state, I mean, that fund can be used for that, right? To build out your capacity for 24/7 crisis response.
Yeah, so I believe all agencies are working towards that. Our goal is to do centralized dispatch, 988 dispatching mobile crisis, and then that connects to the CCBHCs, but to articulate the specifics, I'd have to just double check with Samantha Sweet on what the specifics are. That's a good question, Daisy.
I have some more questions. Yeah. Just generally moving away from 988.
Have we covered? Or are they new questions? Are they pertaining to things we've already talked about?
No, just overall.
Okay, so can we go through and then get to
Yeah.
the end and then we'll ask them? That'd be great. Yeah.
We did want to highlight where things are at with suicide and rate of suicide deaths. We are working on finalizing 2023 data and can share that it's looking very similar to 2022, and I'll show you that in a moment. Our rate has come down since 2021, but as you can see, it's still on this fortunate incline that seems to be happening, over time in Vermont. So it's very much still an issue. We lost 125 lives in 2022. And on the next slide, I'll talk a little bit about what 2023 looks like. So if you haven't seen it on the Vermont Department of Health website, they now have a dashboard. You can look at suicide deaths as well as look at how many people are visiting the emergency departments due to suicidality. And those are two really good indicators, because, and we also see some differences, actually a lot of differences, in who shows up to the emergency department versus who's dying by suicide. This is deaths. And so the light blue is your 3-year average looking back across January to November, and the dark blue is 2023. And so November and December haven't been filled yet. We have about 60 pending death certificates. So that these numbers could go up. It's about, there's no statistical significance right now for the difference between these two, but it's sort of yet to be seen. I think on the top you'll see, which has been a constant for Vermont firearm, by far the highest needs, as followed by 14 deaths, or followed by suffocation and hanging, poisoning. And then I think over here, you're seeing it's still the vast majority male. We have some increase in 25 to 44-year-olds in 2023. And we are seeing a higher rate in our white population versus our non-white population. And so those are some of the things that we're looking at, but I think we'll do a deep dive with the Department of Health. They've really come up a long way in what they can pull for data in real time on this issue.
Melissa, Topper, Brian.
So last year we did, and I don't remember the number or the act number, but sort of around education, wondering what over the course of the last year or plans moving forward, what are you doing around education, suicide prevention?
On the bills we
And
passed
on the bills we
specifically.
passed.
For the protocol,
For more for the protocol, but then also the safe storage change.
so a lot of that work is happening through the CDC grant and through the Department of Health because they do the injury prevention. So safe storage has really come out of their lane. So I might, in work, will be coming to talk to you about that, but it's definitely in their camp. Well, I think Nicholas will probably speak about that.
Do you keep statistics on the number of people that actually call and whether or not they committed suicide or they didn't? So in other words, because they called 988, that saved their life.
So yes, so those who died by suicide versus not. So yes, there is one thing we can't do is follow somebody, right? So it could be somebody made a call and then the following week they might have acted. That we don't have. But we do have data on how many required an emergency response. So it was the situation was dire enough they needed immediate help. And so somebody may be dispatched to their home. So they have data on that. The number's really low. It's in the 1% to 2% right now of anybody needing an actual physical response. Well over 95% are fine with just somebody to talk to and don't reach that level. But some have needed an emergency response. Either they attempted or they called because they attempted, or they were clear that they were about to and they needed an intervention.
Then are you able to track those, what happens after that response?
I think that's part of this IT solution. We don't have a really robust place to say, was there a follow-up? What happened? Did they get connected? That's part of that $955,000.
Okay.
Build that.
Okay. So I don't know if there's a way to know this, but I'm observing how it looked like we were doing better, so to speak, and the rates were decreasing. And then in May, there was a spike that brought us back to like the average, or I think that's the average, right? I don't know if it's a median or an average, but whatever the light blue line represents the sort of summary of the years before. And then I noticed a huge spike in July, and it's hard to not speculate if the spike in July is related to the mass eviction of hundreds of people on July 1st, followed by the flooding on July 10th and 11th. Both of which displaced people from housing and being such an important social determinant of health. Is there any way to find that out, or do we really not know why? What led to death by suicide?
So really interesting question. The place that we have information around a deep dive into, well, I'll start with this. Really hard to answer why all the time. I know you know that. We have found some population differences. For example, in some of this information, if you go on the VDH website, you'll find the full data surveillance. And it has info on if you're housed versus unhoused, what's the difference in death by suicide proportionate to that. So they did a really nice job of trying to dig into what some risk factors are. The other thing though, is when you see these ups and downs per month, it's actually not a significant difference. If you were to look at it statistically, we're a small state. So sometimes it can look like an up, but it's two individuals and two is too many, but it's not a signal of a spike.
That's helpful to hear that.
Well, year over year, that's the thing to track in terms of, or maybe looking at a quarter one year versus a quarter in another year. Those kind of things.
Thank you.
Okay, thank you. Keep going.
Okay. That's okay. Good. The next item here is private non-medical institution increases for rule changes. It's $100,000, $100,800, or general fund equivalent of $48,772. So the DEVA rate setting unit is proposing rule changes in an effort to stabilize the PNMI system. The cost addresses changing 3 different rules that are being proposed. Salary cap. There's currently a rule that states the highest paid staff cannot exceed 7 times the lowest. So that rule is being asked to change. There's another one that caps a surplus. Anything above 5% is recaptured by rates the next year. And then reimbursement for closed beds. So this allows for reimbursement for closed beds for typical placements.
Questions? Very quick. This rule is, so it's a DEVA rule. It's not throughout the entire state government.
It was a DEVA rule specifically for the PNMI institutions. And so what we found was that it limited their ability to provide psychiatry services. Yeah. And so that's not a similar a parameter around say hospital settings.
It's just for PNMI.
So is there a way to address it? Because we need psychiatrists or.
Yeah, this is getting rid of that.
Oh, I get it.
This is it's a rule change that DEVA is requesting.
Okay, thank you.
It has to go through the legislative process.
That's good to know.
Whoops, I'm sorry.
That's good to know.
Okay.
Thank you. You'll put pressure on those people.
There's another line item for PNMI also. It's another change around inflationary increases. So the way that the rates are set, they're set based on historical expenses, and it doesn't allow for increases that happen. So this is an inflationary increase request.
We had talked about this, I think, during last year's budget. Okay.
This one here is mobile crisis response. This is simply just converting what we got in our FY24 budget cycle for the uninsured and underinsured from general fund to global commitment. We asked for a global commitment investment. We were granted that investment, so we were able to just move that funding, saving general. And then this one, I'll let our commissioner talk a little bit more about this, but this is a $275,000 request again for the Act 57 during the FY22 legislative session.
And so what this does and has done is provide 2 attorney positions with Vermont Legal Aid to assist representation for individuals through the criminal court process in collaboration with their defense attorney. And so we want to continue having Vermont Legal Aid support those individuals through that process.
Is anybody doing that now?
Yes,
How many do you have now?
it's two.
And you want to increase it by two?
No, we would like to keep the same two.
Keep the same two, and that started in 2021.
Yep, 2021, age 57, was the act. There were a few things that came out of that. It's also called S3. But the money pieces, related to the legal aid supports and then the conflict counsel, were one-time dollars, that we would like to continue, those programs moving forward.
And what do those two attorneys do?
They represent individuals in the criminal court proceedings where competency is being challenged. And they support the work of their defense attorney.
Yeah, is there, if this is an ongoing expenditure, would it make sense to put that in a base?
It is
That's
a
what
base.
this request.
Yes, this is a base request.
Okay, I'm sorry, thank you very
Okay.
much. Yeah, okay.
Good to confirm it.
Not a one time, thank you. So,
The important thing though, is it's not additional.
Right.
That, I was confused when I read this.
Yeah.
The cost of additional staff.
It's
Okay.
saying it was one-time funded.
Yeah.
For two people, now we want to put it in the base for the same
Yeah.
two people.
And it showed up in our BAA last year. And it's, I think we neglected to put it in as a request for a base budget, but we figured that out. And yes, this is a base budget request.
it's right here in the language.
Easy to skip words.
Additional is confusing because it makes it sound like you're adding more.
Okay.
Okay.
We can,
Yeah.
thank you.
Let's pick this part, but do you have a sense how busy these folks are? I mean, if somebody already has a defense attorney, what do these folks do that defense attorney can't do? It
No,
seems like
that's,
a lot of resources
yeah.
given to these folks where somebody else may not get it.
Yeah, that's an important question. I believe there is a piece, and Vermont Legal Aid could articulate this better than I could.
Yeah.
But I believe there's a piece in the court process that transitions the representation away from the defense attorney
Okay,
to the legal aid attorney to
Okay.
represent the wants of the individual involved in the court process.
okay, thank you.
And Vermont Legal Aid, their role in our system is really important. And their knowledge of the nuances of least restrictive setting and what an individual's
Yeah.
rights
Yeah.
are really valuable when it comes to the criminal justice system. And so I don't see it as a duplication of services, especially when it comes down to someone's competency or incompetency.
All right. Thank you.
It is legislatively mandated too.
Yeah.
So we have to fight
We have
it.
to. Nolan?
There was 3 things in S3
Mhm.
and you addressed some of them. So you just asked for 25,000, which was actually for, I found my fiscal note, which is the support work and forensic care, which would make that base. So those-
25,000 was conflict counsel.
Yeah, okay, that's not what I said. You should know more than I was. The other thing that's in here was independent evaluations.
That's correct.
Is that also base or is that one time? What's happening with that? Because you're switching a lot of these S3s from one time to the base, so I'm just curious about.
Yeah, so the 275 is 250,000 of it is for the legal staff.
That's okay.
I should definitely be clearer about that in the narrative. $250,000 is for those staff, and then that's what the other $25,000 is for the evaluation.
Evaluations, yeah.
And that's based on what happened. I think the first year, nobody knew how many evaluations are going to be needed.
Yeah.
And so we kind of based it on what the history,
Mhm.
what the history was.
Right, and then we had the backlog of our evaluations
Okay,
in
makes sense.
in additional years, and that backlog is gone. And then also the separation of, competency and sanity. All looking at those costs.
Jane, if you can update the narrative, that'd be helpful.
I will do that.
Thanks, Daisy. And then Daisy, I also, before we go to the residential treatment, so ask this question, but then I want to go back to your other questions before we move on to a new policy. You had some questions about.
While we're in S3, was that 250,000 supposed to be split? Weren't we supposed to move the funding responsibility from DMH to, you know what I'm talking about?
I do. I don't think that, that made it into the final, legislation.
Okay, because I'm just thinking while we're revising it.
I can check with Karen Barber on that.
Yeah, she'll remember.
Yeah.
Okay, so you had other questions about the budget?
Yeah, Shannon, do you know what the overall increase is this year over 24%?
Yeah, you mean the total amount or the percent?
Yeah, I was gonna say, let's do both, because I have a feeling we're gonna want both.
Yeah. Yeah, so the overall increase is $3.8 million. It's that $3,890,000.
Yeah.
Oh, right, okay, yeah.
Which represents a little over 1%, but I can get you exactly, that would be helpful.
Okay.
That's the whole DMH budget?
That's the request. Were you asking for the request of the?
So my question was the total budget, what's the increase year over year? So FY 25 over FY 24 total request, and you're saying it's around 1.2, right?
It's a gross of $3,890,901. The general fund equivalent to that is 1.2, 1.5.
1.5.
But it's a little over 1%. So our budget is 321 million. It was 317 million in fiscal year 24.
And the bulk of that, is it, I'm just kind of glancing at this, at the spreadsheet from the AHS, whatever that Nolan sent us. It looks like a lot of that cost is in, or the increase is in salaries and wages. Is that true?
Yes, well, I mean, probably that's one of the biggest line items, just because we don't have control over the salary and wages. It's the steps and the cost of living. And then it's the retirement increases. It's all of that. That's
automatic.
Just into that. Yeah.
And so is it fixed to inflation, or?
It's based on the steps, the negotiation, the BSEA negotiations, right? So we have the pay grades and the steps. So it's based on what people are getting paid and what they're going to be getting paid through fiscal year, at the start of fiscal year 25, what their salary is.
As part of the collective bargaining agreement.
Thank you.
But I think what you're asking is whether or not it's COLA, that there's a yearly, yeah. And I don't believe is baked into the collective bargaining agreement, but BSEA or HR could ask. Is that?
It's baked into the chart of pay grades and steps, the cost of living.
Over the course of the year? Okay.
But this budget here is what it looks like, what it's supposed to look like starting July 1. So it includes what happened in fiscal year 24 to get to the start of 25. All of this steps in COLA for 25, you're going to see in the next year's budget.
Got it. And you mentioned the Integration Council's report and how central that is to the thinking of the department. And I very much appreciate the process leading up to that for years and how comprehensive it was and represents so many voices across the state, right? And if everybody on the committee hasn't read it yet, I strongly encourage you to go back and dig into it. They have a great spot on the website. I can send everybody a link. But I am so impressed with the way that you keep that thread, because it is so representative of people who need mental health supports. And I see it's really clear that the recommendations from that report are not reflected so clearly in the budget. And I'm sorry to see that, but Thank you for all of the great work that you're doing.
And we will at some point have a testimony on that mental health integration report. Did you have anything else? No.
I just wondered, the 317 from last year, does that include the budget adjustment that you asked for, just, I don't know, it seemed like the other day?
No, that's the base. So FY 25 has to build off the FY 24 base.
So what did you request in budget adjustment this year?
Oh, I think it was a
3 million.
around 3 million. Sorry.
Yeah, it was the visiting nurses, almost 2.7.
Yeah, for travel nurses.
We add that to the 317, that's 320, and you're 321 this year. Thanks.
Hold on, Melanie.
Oh, I think Leslie asked it earlier. I think I just was so surprised that it was only 1% increase, knowing that this was the governor's ask, like the second bullet saying like we just mental health and all of the expansions that we've done. I mean, it's so impressive what's been done in the last years, and then federal money going away. So just being like understanding, is there anything? I don't know how to even ask it. I'm just as curious as to, is this enough? Are there things that you want us to know about?
I mean, I think Leslie asked the question in the beginning, and so this is a good time to stop and talk about it. You know, we would expect to see a higher requested increase because we still, although what we're hearing, the work that's happening is amazing. We've been, several members have said after the last couple of meetings, like it's a much different feeling this year than it has been in the past. But we still have people in crisis.
Absolutely.
And so just, you know, and we asked this question a little bit yesterday with Diva and they couldn't answer, but I'm hoping they'll come back to us. But like, what was pushed up at the agency level that was not accepted that you think is important?
I think one, well, first I want to say the department bit off a lot of initiatives last year. And we're starting to see some of that work, and a lot of that was a mixture of federal funds that haven't necessarily expired yet. And so there's also the dance of wanting to make sure that we're investing in the things that are really changing people's experiences in the community. And that does take a little bit of time for those programs to come to fruition. And so, you know, I don't know very many people who are gonna say, we'll take all the money you want to give us. Because there's some truth in that. But we also want to be really responsible with that. So, you know, we do have some information, you know, that Allison can help us go through around caseload hits and how many people are being served in their communities, and really targeting those specific programs and services to look at where those gaps are. I know it's a long-winded answer and not really an answer. But we still have some stuff that are coming on board, but we also need to really be specific about the other things that we're targeting. So maybe that's a good leeway into some of our dashboard info. Do you have anything you want to add for that?
I would just add that through all of this work, and I think the Mental Health Integration Council also in particular broadened your landscape on who should be helping with mental health. And so I think that there's other mental health initiatives happening in other parts of the state that shouldn't be discounted, and those take funding. And we're working on refining what, you know, programs, just like the commissioner said, are best serving. And we're pretty close to seeing that come to fruition. So we're excited about what we could say to you on the time to stay invested.
Yeah, and we're excited too. Don't take this question as the wrong way.
I'm not gonna cry today.
Okay, good. I have a question. Is there any ARPA dollars that you have that are not out the door?
We will, let's transition into some of those community investments that you aren't seeing here.
Okay.
We can give an update on those and those ARPA dollars.
Okay, and before we do that, I have another question I want to put out there. Reimbursement rates or any type of increase to the DA's SSAs, there's nothing in here. So there's no decrease, there's no increase. Are we at the same level we were? Like we had an 8% increase, we had a 3% increase through ARPA funding. Is all of that in this budget? Are the DAs through this budget level funded?
So let's talk a little bit about, let's talk about the ARPA funding real quick. Sorry, Nicole.
And that's fine. And if we might
And
need
maybe
to come
we,
back.
yeah, it probably is worth coming back because I think, we have some data related to services delivered in the community. That I think will be really important for us.
Great. Yeah, I mean, you have a lot in here, so. We'll have to come
Yeah,
back.
we really do. So from a, community investment perspective, you talked a little bit about the ARPA dollars. Almost all of that is out the door. I think we have around maybe 55,000 or so left to get out the door. And those have been utilized to do some of the renovation work across the system that folks needed. Additionally, with the community provider stabilization, the loans, those have made impact in our community. I think we've seen the number of open positions start to decrease. We're seeing turnover starting to decrease. And so that is reflected in the data that we're getting from our partners.
So that's that 1.25 million.
Yes.
And that was one-time funding.
Yes.
And then I see what's the employee investment program. So is this a separate program from that 1.25 million?
Do you want to talk a little bit about the 3 million, this down here, the employee investment program? Because is there a separate one that goes through VDH that's outside of our budget?
I think so. This is funding that we got in the legislative session, I believe, and we've grossed 3 million up to 6.9 million to maximize use of that. So we requested an investment. So that is, we still have to develop that.
Okay, so this is money not yet out the door.
Correct.
It's not yet out the door.
So although we had one-time funding of 1.25 million, it looked like it helped, help stabilize workforce at the DAs. My concern was, well, there's no more funding to continue that, but there is, we just haven't gotten that out the door yet. And is there a time frame for this investment program? And if it's not ARPA dollars, it doesn't seem like,
I
okay.
don't think it's ARPA dollars. And I don't believe there's a time frame.
Okay.
We can confirm that with you.
We can get you more.
Or like what your timeline is of getting the program up and running and how it's all gonna work.
Okay.
More information on that would be great. Daisy?
You're talking about the 1.25.
No, I'm talking about the employee investment program.
Below it.
Okay, the community provider stabilization 1.25, that's been allocated. It's not out the door yet, right?
The 1.25 is the one that AHS implemented. Yeah.
Okay, and what was the total amount appropriated of that fund?
I'm not sure. That was, I can get you that information. That was sent out by AHS. So I just don't have that information.
Okay, I'll look it up. I have the AHS one.
I just want to clarify. I understand you have 308 staff positions?
Yes, for DMH,
Yeah.
correct.
So I was just wondering how that reconciles with 500 staff. How does that
Two
work?
separate things. So none of the VPCH staff or state of Vermont staff received community provider stabilization dollars, two separate. So
Okay.
those 500 staff that received a total of 1.25 million in forgivable loans are within our community system.
That's the DAs.
Correct.
That went to the DAs. Got it.
Correct.
Yeah, so Shannon, if you can provide more details on those, it's confusing. So what's actually gone out the door? What do we still have to go out the door? And what's the timeline on getting that out the door?
Yes.
That'd be great. Thank you. Okay.
And then the next slides are graphs related to the designated agency and SSA vacancy numbers. So you're starting to see those vacancies come down.
Great.
And then this breaks it out by program. So folks with developmental services vacancy rate, mental health, substance use, admin, and then the overall. And we thought we would compare that to the experience at VPCH, River Valley, and the Department of Mental Health. Because we oftentimes hear compare the facility staff vacancy rates to our communities. And so from a facility vacancy rate, we are sitting at around 47% vacancy rate and 42% vacancy rate, respectively, at our facilities. 12% at central office and 38% as a whole of a department. So we just wanted to take an opportunity to show those differences.
So just, I guess, expand, like, what do you want us to take away from that?
I think from my perspective, we often get compared to wage differences between the two, and that equates filled positions. And I think that there's an assumption that it's much easier to fill state positions than it is community positions, and I don't necessarily think that's always the case. There's complexities to our system, who holds the right licensure to serve in certain positions. And I think it's just helpful for folks to know that there are vacancies across the system. We have some folks who are as low as 5% vacancy, and we have some folks who are much higher than that. And when you compare to the department's work, it's pretty dismal here too.
Leslie, did you have a question?
No, this is really helpful. I'm just wondering, this is maybe not something you know, but how many at the designated agencies, SSA, is, what's the workforce, the number, the absolute? Because I'm just trying to understand the vacancy rate in relation to the entire staff.
Yeah, I think if we go back to one more slide up, yeah. I think what you're asking is how many staff members as a whole work in the designated.
Yeah, what's the
agency.
denominator? I'm asking again.
I don't know the total for that, and that might be something VCP can speak to.
Thank you.
Vermont Care.
We'll come back when she comes back. Maybe you can provide that information. Thank you. Brian.
Just curious, it's probably, the vacancies are probably across a lot of different positions because that's what happens, but I'm just curious, like, how do the vacancy rates compare between the state jobs and the community-based, like private, nonprofit, jobs, whatever? And how does acuity play into it? Because I know that state workers staff some of the highest level of care facilities, but we also have like Brattleboro Retreat, which is not a state agency, who also has that. So I'm just curious if you know what role acuity might play with recruitment and retention of staff, because the jobs are getting harder to do.
Yeah, that's a good question, because I think acuity looks different depending on what position you're interested in, and also how we talk about our community members. And so when we talk about human services positions, I think we sometimes the message is, why on earth would anybody go in? Because you're going to get injured, or it's so terrible. But that actually isn't the case. It's a very fulfilling work to be a part of. And as long as we have tools to train folks around acuity to work with folks who are experiencing a hard time, I think the different levels of care within our system should be able to address adequately those acuity changes. But I do know we have safety concerns in our community. And I do know we have safety concerns at our highest levels too. So acuity may be impacting that. I think in general, what's really hard to staff is 24/7 facilities, whether you're running a crisis bed at the community or a hospital. It's really tough to find overnight staff.
When I was talking about acuity too, like I hear your point, which is that different people's perspectives, like some people think that someone yelling in front of their store is like like a store owner might think that's a crisis and another person might not be fazed by it. But I was thinking more like, vicarious trauma, like the impact of that on staff. And so what I'm hearing is training helps, which is good to hear that like that the department's continuing to look at training to help people have the tools to manage the acuity. I'm curious what about like restorative or regenerative practices for this staff in terms of just helping them with self-care and healing and like managing exposure to trauma?
That's a good question.
You don't have to answer it now either, but it comes to mind.
Yeah, no, that's a really good question. And if we haven't defined, specifically how we're approaching that more broadly, we need to. So let's come back to that.
Thank you. Yeah, I don't want
to. Yeah.
Art?
Yeah, the chart several down that showed the lines of vacancies. For the jobs that are state-based, of the salaries and benefits still in the budget for these positions?
Yes.
Okay, and how long, do we know how long some of them have been? No, some of them. Well, just got 1 year, but how long some of them have been vacant?
Some of the facility positions have been vacant for some time, but they rotate new permanent staff into the oldest position numbers.
Okay.
But what I can tell you is that it takes around 63 days to fill a position at the facility. And so when you're in a competitive market of staff, 63 days is a long time for somebody to go without a job while they're trying to interview and get in the door. So we have to figure out a way to look at our hiring practices so that we knock that down a little bit. And I think there's, I think it would be helpful, for our community to talk about their recruitment and retention strategies. Do they have something that's easier or a shorter amount of time from application to hiring? Because in most settings, 63 days, you lose your applicants.
Do we track the amount of money per year that's tied up in unused, their wages?
Under vacancy
So
savings.
We know what we're talking.
I believe we track those dollars under our vacancy savings dollars.
Yes, vacancy savings is used a little bit differently at the hospital and the residential facility. Central office, where we are asked to assume about a 4% vacancy rating in our budget. So that's how we budget. At the hospital, we have a much higher vacancy savings number because we have contracted travel staff. And so we're trying to be, transparent about where we're spending our money, and we're spending a lot of money on travel drivers. So our
That's where that
vacancies,
money goes.
the vacancy savings is much higher in those facilities, but so are the contracted positions. And salaries.
Yeah, thank you. I'm trying to figure out if, when I see all these vacancies, I'm trying to figure out if that has any impact on our wishes to have people placed in state.
That's
And the trend that's going on to placing people out of state.
That's a really good opening, if you don't mind, for us to talk a little bit about our psychiatric residential treatment facility, which speaks to that a little bit, especially with youth. So Vermont currently does not have a PRTF. We send kids out of state to receive this level of care. Primarily, I think we have a couple of places in Florida where folks go, but pretty far away. So there is a project and a budget request related to a PRTF that's happening now. I think it's in NEVA's budget, if I remember, which has been a long time project. I remember an RFP going out maybe when I first came in as commissioner. And then the DCF had to repost that RFP. But the most recent bidder on that was the Brattleboro Retreat. And so folks are looking at contracting with the Brattleboro Retreat to potentially provide this level of care there so that we're not sending kids out of state to receive services. From an adult perspective, we don't send a lot of adults out of state. Some may go out of state for substance use residential programming, but that's on a voluntary basis. Some adults may go to another state through our interstate compact process on an involuntary basis, but that's very, very rare. I've only seen that happen once in my time at the department. So most folks who are getting sent out of state are younger folks. And so that's the push to hopefully incorporate a PRTF into our system.
So that's the path forward,
Mhm.
get back on track about
Sending folks
people
out
in
of state.
state.
Mhm.
And can you explain how PRTF is different from what Brattleboro does today with youth?
Yeah, so oftentimes when people think about the Brattleboro Retreat, they're only thinking of hospital level of care. But the Brattleboro Retreat also provides numerous outpatient services. And the PRTF is considered an outpatient service, like, I guess. It's not a hospital, but it's also not one time a week, therapy. It's residential where folks are staying anywhere from 3 to 18 months and getting that intense family work that folks need in order to step back down into their communities. And so this is just would be another level of service delivery that the retreat could provide.
And so if the retreat is doing this, I'm assuming they're using beds or a facility that they have today. So are they taking anything offline to do this?
No.
So where's the space?
The space is currently tabbed for Linden Lodge, which was a renovated space. Yes. Does anybody remember the Linden Lodge? So what we supported the retreat doing is they expanded their level 1 involuntary beds from 14 to 26. That's the original use of the Linden Lodge. That was also really difficult to staff because you had high acute folks experiencing high acuity in 2 separate parts of their campus. And it made it really tough for your highest skilled staff and psychiatrists to respond when they needed to respond. So those units are all now together in one area of the Brattleboro Retreat. And so it made sense to start having all the youth stuff in one section of the campus. And so the Linden Lodge was a really nice opportunity to make use of that space.
I know Brian has a couple of questions. I'm going to let him ask questions. Then we're going to end and have you all come back. Sorry.
Yeah, because I'd really like for us to get into the other data components.
Go ahead, Brian.
I'm sorry to ask, but I think it's important, just to get some clarity, that this sounds like it's a replacement for justice involved youth. It's a facility for justice involved youth that provides mental health and substance use disorder and, other kinds of, I don't know, I don't like using behavioral health, but yes, that kind of treatment. And it sounds like it's gonna fill a niche that Woodside used to fill, but Woodside was a correctional setting and it didn't provide treatment.
Oh, yeah, so I get why that can be confusing. No, so this is separate from any programmatic or facility replacement for Woodside.
So these aren't justice involved youth, they're
No,
totally voluntary?
Not particularly.
Okay.
Yeah,
Okay, that's good to know.
yeah.
And then that was one question.
This is really starting to transition, anywhere from, I think we have around 29 DMH folks who are out of state. There are maybe 6 or 7 DCF. We have numerous kids out of state. And so
Yeah.
what this would do would transition them closer down.
Yeah, and it seems like an appropriate response versus like a correctional facility to have a mental health facility for people in the long term to get the treatment they need. So I appreciate that. Is the plan for it to be run by state employees or is there going to be a contract? I don't know
It's
if
a
I missed-
contract with the Brattleboro Retreat.
Okay.
Yeah.
So there'll be employees at Brattleboro Retreat.
Yeah.
And then and then this question you may not be able to answer today, so I'll ask it and then it can float out there and someone will answer it, hopefully.
Yeah,
You were talking about how this plan will bring youth home from out-of-state placements and that there's not a lot of adults in similar placements out of state. But I know there's a lot of adults in a correctional facility out of state, and I'm curious if we know how many of those adults need secure residential recovery facility style settings versus correctional settings in order to really heal and reintegrate into the community. someday.
yeah. I'm picking up a theme from you around wanting some more information about how people are doing in corrections. I don't have a lot of information of what folks who are incarcerated are experiencing in our out-of-state facilities. What I can tell you is folks who are incarcerated in Vermont, if they need a higher level of care, like a hospital setting, and whether that's voluntary or involuntary, we have a very close process with Department of Corrections to get access when folks need it from a medical necessity lens. For folks who are reentering their communities, we'll also, and they are connected with a designated agency, we'll go through those. The designated agencies will go through those screening and assessments with them for levels of care. But if somebody is adjudicated and has a sentence, you're not coming back, you're not leaving your sentence and going to, say an intensive residential and then coming back.
And there's no option within the correctional system to provide that kind of care right now.
Not currently.
Yeah. And I think the theme that you're picking up is justice involved youth and adults, because it's not necessarily like corrections, because you're working with DCF too. So it's like DOC and DCF.
Yeah,
And
and
the
diversion, the Attorney General's office,
Okay.
and your local community restorative justice. Yeah, I hear you.
All right, thank you.
So thank you. This is helpful. I'll have Claire reach out to the schedulers to get you back in. We do have some time next week, so hopefully you all will too, and we'll keep going. So thank you for all the great work.
Yeah, thank you.
Thank you.
Thank you.